Hi everyone, thank you for coming. So before we start into, sorry. So before we start the discussion, I wanted to give a chance for everybody to introduce themselves. If the rose of you.
Oh, sure. Well, you probably saw my bio on the website or in the information, but I'm a Catholic sister. I belong to the Daughters of St. Paul. I've been in my community for almost 60 years. I entered when I was 3. No, I was in high school, so I finished high school in Boston. I entered here in Boston. And for those of you in Boston, in Jamaica Plains, where our main house is, we work in communications, and over the years, I got involved in media literacy education, and I got to go to London for my master's degree there and in education and media studies. And I've been working in that field since 1995. It's been 30 years. And for 20 years, I was in Los Angeles, and I didn't plan this, but I became a film critic for 2 Catholic journals. That was fun, but I got tired of deadlines. You ever get that feeling? So I asked for my 50th anniversary in the convent, I asked to go to Rome, and I'm still there, but I'm alone. This is really my home base. But so media literacy education is really my main focus, and I'm not a medical professional, but I am a professional patient, and I will explain that to you later.
Am I on here? How about now? Testing. Hello. I'm a systems strategist and anthropologist, and I've worked with indigenous communities for about 30 years. Sitting at the feet of a lot of elders and listening and looking at the patterns and the science and the infrastructures and the ways of being and seeing the world.
Can you
And
speak
then
closer
bring
to
that-
the mic?
We'd love to mic.
Or maybe just give.
Your beard.
Exactly. Move it back off. How about that? Does that work, or should I just use the other mic? Yep. All right. I don't remember where I was, but I've worked with indigenous communities for a long time, looking at the patterns, and then and now taking that into artificial intelligence and the frameworks of artificial intelligence and ground that its behavior in indigenous principles, values, and things like that. And I've worked with a lot of leaders to help them think differently about the problems that they're addressing and about the values and the principles and priorities that prop up the systems that we operate in today.
Good afternoon, everybody. My name is Lisa Lehman, and I'm a primary care physician and a bioethicist, and also a clinical researcher. I've been on the Harvard faculty at Brigham and Women's Hospital for about 25 years, practiced medicine at the Brigham, and currently actually work as the director of research at Verily, which is a precision health AI company spin-off of Google X that is trying to empower patients with improved health outcomes using AI.
Can everyone hear me? All right, perfect. So my name is Katya Paul-Laurent. I'm CEO and founder of Harmony IQ. I also hold other titles. I'm a researcher, birth doula, and traditional medicine woman. And so what that actually means is I take the whole body and the system that my patients they come to me, and I treat across the layers. And in an ideal world, it would be amazing to work alongside another provider who also understands and acknowledges and respects what I do. But, we're on our way here, and I'm glad for this event today. And so one of the things I do is, based upon the audience, I tailor this. So just understand, because there's a lot of physicians and researchers. So Harmony IQ, we are building a clinical grade decision support grounded in reproductive equity for birthing, for people who look like me, and also LGBTQI plus families that they're struggling with infertility. So we combine peer-reviewed evidence, real-world patient data, and what we call an embodied ancestral intelligence. And so That methodology treats the lived experience alongside all the other things that we do know as far as forensic medicine.
So, okay, so I'm a nun, so I actually wrote it out and prepared it. Ran it through AI to make sure it was 60 minutes, because they're sharing 40 minutes, so I don't want to go over any time. But, so I titled my presentation, Health Equity and Other Ethical Assumptions in AI Medicine and Education. When we hear words like neutrality, efficiency, and innovation, especially in medicine and artificial intelligence, they sound reassuring. They suggest objectivity, progress, and technical excellence, and health equity. But one of the central ethical questions for us today is neutral for whom, efficient for whom, innovative at whose expense, and are there biases involved? The real question is not whether they are embedded biases, but where are they hiding? My work as a media education specialist sits at the intersection of Catholic social teaching, critical media education, media ethics, and social justice. What I've learned both from ethical tradition and lived global experience is that systems rarely declare their values outright. Instead, values are embedded quietly in design choices, research protocols, data sets, and even in definitions of what counts as normal or evidence-based and experience-based. Let me begin with a concrete medical example. As I said, I'm a professional patient because I was diagnosed with multiple sclerosis 30 years ago. But I'm not going to talk about MS. I'm going to talk about when I started taking statins for cholesterol. Early statin trials, particularly those shaping the use of lovastatin, were conducted primarily on white male bodies. Women were included, but not in sufficient numbers to generate meaningful or protective data on dosage, side effects, or long-term risk. The only warnings I remember on the medication I was taking was don't drink grapefruit juice and don't walk in exposed sunlight. There was nothing else about warning on the label. As a result, women's harms were undermeasured, underrecognized, and often dismissed as anecdotal. Yes, statins lower cholesterol in both men and women, but at what cost? Including depression, which was my experience. This is not merely a historical oversight, it is an ethical failure. To take medications developed for men and throw them at women without checking them out, without testing them, is wrong. Why? Because clinical trials do not remain in the past. They become guidelines. Guidelines become standard practice or standard of care. And try to change that. And those standards are notoriously difficult to question. Think, for example, about routine mammography. Why is ultrasound not used first, given that repeated radiation exposure can cause cancer that you're trying to detect? Talk about counterintuitive. I suspect profit and investment plays a role. And I also ask, how many women were meaningfully involved in shaping these diagnostic systems? Today, these standards are increasingly embedded in AI-driven clinical decision tools. When biased evidence is treated as neutral data, bias doesn't disappear, it hardens. AI does not create bias, it scales it. It automates it. And it gives it the authority of mathematics and data. This is where the language of efficiency becomes dangerous. An AI system that produces recommendations quickly and consistently may appear efficient, but if it is built on evidence that excludes certain bodies or experiences, I mean, we're talking women, but what about people of color, right? Then efficiency simply means faster inequity. Neutrality becomes a myth. Innovation in and of itself becomes morally hollow. Here I want to acknowledge Joy Buolamwini. I don't know if you've heard of her. She was a researcher here at MIT. She uncovered racial bias in facial recognition systems. Her work, documented in the film Coded Bias that was on Netflix for a few years, they took it off. I hope they put it back. revealed that algorithmic systems consistently misidentify darker-skinned faces. In response, she founded the Algorithmic Justice League to mitigate AI harms and advance the field toward accountability and equity, including health equity. Her work reminds us who codes matters, how we code matters, and that we code a better future. Catholic social teaching provides a clear ethical lens here. Human dignity is not abstract, it is embodied. Justice requires that the benefits and burdens of innovation are not unevenly distributed or made inaccessible. The common good reminds us that technological progress detached from moral responsibility is not progress at all. What concerns me most is not malicious intent. It is something more subtle. The assumption that if a system works, it must be ethical, and that few people feel authorized or confident enough to question those systems that enable it to exist and prosper. We see this assumption everywhere in medical education, AI development, and workforce training. We teach future clinicians and technologists how to use tools, but not always how to interrogate the moral history embedded within them. We train for competence without a holistic approach to education. This is why I argue this clearly. There can be no ethical AI without ethical evidence, and no ethical evidence without education. Education of conscience, imagination, and responsibility. This is where, as my colleague here said, indigenous and ancestral wisdom alongside religious and ethical traditions becomes essential, not supplemental. Indigenous and ancestral ways of knowing begin not with abstraction, but with relationship to body, land, community, memory, and story. Knowledge is never detached from responsibility. Knowing always carries obligation and openness to change. Yes, change often has a price tag. Profit is always involved, but at what cost? I'm almost done. From this convergence, emergence of pedagogy we urgently need today. Senti pensante, it's a Spanish word. A way of knowing that integrates sensing and thinking, heart and intellect, lived experience and critical analysis. This pedagogy, developed in Latin American context by educators such as Orlando Falls-Borda and Laura Rendon, resonates deeply with the liberative and liberating vision of the great Brazilian educator Paulo Freire. In practice, Senti Pensante pedagogy guides learners through three intertwined movements: to sense, to think critically, and to respond ethically. It resists the fragmentation so common in technical education. It forms professionals capable of handling complexity. Who can say this tool is powerful but not neutral, useful but incomplete? If we do not form clinicians, educators, and technologists to recognize ethical distortion early on, we will continue producing highly skilled professionals who may unknowingly reproduce structural harm at scale. Pope Leo XIV, I was there in St. Peter's Square when the white smoke came out. That was awesome. Reminds us that technological power must never overrun moral responsibility, and that innovation loses its soul when it forgets the human person it claims to serve. The question before us is not whether AI will shape medicine. It already does. The real question is whether we will prepare humans capable of shaping AI to serve the whole person, human dignity, and the common good. Thank you.
I wanted to start off by first asking the panel to all, if you would like, share a moment, a personal or professional one, when you realized that the way medicine is usually taught or practiced wasn't enough to hold the full reality of care, healing, or human dignity. What did that moment teach you about what must be present for care to be just? Who would like to start?
Maybe I'm happy to start, and I'll apologize in advance because we started a little late, and I have a hard stop. I'll conflict a little bit before 12, so I'm going to have to slip out. So apologies. So I spent a good part of my career as an ethicist and also teaching medical ethics. And one of the issues that came to that I encountered actually initially as a resident. I was in the emergency department and we were resuscitating a patient. I trained at Hopkins and East Baltimore. Patients would come in with trauma, and a patient came in with a young patient with a gunshot wound, and we were, doing a code, trying to resuscitate this patient. Young patient, you always want to do everything you can, keep going, keep going, keep going. Unfortunately, the patient didn't survive, and the attending at that point turned to me as a medical student and said, well, do you want to practice intubating this patient? I was kind of taken aback because as a student, I was eager to do procedures. Like I loved procedures, I wanted to learn, but there was something as a religious person, there was something about respect for the dead, and also coming at things from a bioethics perspective, and the whole framework of consent. There's something where you can't get consent from the patient, obviously, who's dead to do this. There's something that just seems so wrong about that experience. So I just quietly said, no, thank you. Didn't know if I was going to be retaliated against in some way or my evaluation was going to be negative. And then I thought about it a lot and continued to be so disturbed by that experience that I went to the chair of the emergency medicine department and talked about it because it just felt so inappropriate. And is this the culture that we're educating clinicians in? Is this what is this like, have we thought about these issues? How we're treating patients who are alive, but also patients who are dead? And this was several decades ago, obviously, but I think the problem still exists on some level. And to the credit of the emergency medicine leadership at that time at Hopkins, there was a real acknowledgement that yes, this is a problem, and a change in the policy officially. Put a footnote there and then move ahead a couple of years as a senior resident in the same institution, running the codes where code team is called to a patient and the anesthesia resident says the patient doesn't survive, and the anesthesia resident says, well, it turns to the anesthesia intern and says, well, do you want to practice intubating since the patient didn't survive? And I'm like, no, we have a policy in this hospital. We don't do that. But somehow it didn't trickle down, and it was really an affront. And I think it goes to so much of what you spoke about in terms of how are we training clinicians? What's the ethical sensitivities? What are people sensing? And are we giving them the moral courage to speak up? It was hard as a medical student to raise these kinds of questions. And then as a resident, to say something to my colleague in anesthesia that this isn't a good, this isn't appropriate. This isn't how we should treat patients. So we need to train clinicians who can try and do that. Just one experience that comes to mind.
Thank you so much for sharing. Jared or Katya, if you don't mind.
Oh, sorry. Just waiting to pass it. I think I'm good with this one. So before I actually answer, I want to acknowledge that as a brown-skinned woman here at MIT, there's a certain amount of privilege that I have to be here and to speak to you all. And then also, given the field of maternal health, I have to also honor Annika, Betsy, and Lucy. Literally, the field of gynecology was built of our bodies. So history does matter. I know sometimes we like to push it to the side and then focus what's in front of us. But in actuality, if that is not no longer a thing, why are more women who look like me continuously dying? And so I think the most pertinent I have many, but let me just do this one. So Harmony IQ, which I built, is based off of how do you actually take community insight and knowledge and move it to clinical action, right? So the one thing I can think about is that I'm a nutritionist, traditional medicine one, herbalist. Sometimes people don't actually understand that, and I have to train them on that. But somebody called me and they asked me, "Are you Katya?" I'm really sarcastic. I said yes, but the long short is I went into assessment mode. I'm like, "Where are you? Your cousin's 38. 38 weeks pregnant. She is 39. You went into the ER. You're in this pod. So you went for imaging, but you should have been back. They should have been back like within like 15, 20 minutes, if that. So most likely they took the patient the back way up to the ORs. So privilege and power, called one of my colleagues and I was like, listen, HIPAA is in place. Do not acknowledge or anything, but there could be a brown-skinned woman who's like, I gave the whole synopsis. And I said, can you please go into the room and let them know that out of all the different people, probably like the junior residents, her cousin is her healthcare proxy, and if they don't have to move on anything, don't do anything. Long short, what happened in that moment, which I found out later, is that the team was trying to decide whether to save the mom or to save the baby. Right? Now, in context, that was her 5th IVF cycle, $60,000 per cycle, not including medication. That was her last embryo. She was a single mother by choice. But in that moment, she couldn't decide for herself. But she's a physician at one of the other hospitals. So irregardless of age and class and all these things like that, when I see data, I see people's lives, and then I take it with me. And so one of the things that I also do is I take people's stories with me to different rooms. And so if we are building the largest individual data set on individual health behaviors of Black and brown women, that comes with, like, using AI, that comes with a lot of responsibility, right? So I'm a good steward and I consider it sacred, but it's also about finding the right partners. I can only do what I can do. Yes, I've gone to Congress. Yes, I've done all those things, but not much has changed. So we need to continually like break the mold and think big. So I would also encourage all of you, as you're thinking about this and going throughout the day, think about how would this apply when I go back in this field? And then also the economics, right? So healthcare in the US is it's driven by the bottom line. But if you replace this, what are you replacing it with that is also making money, right? Because if we don't have enough money, then things shut down, providers go away. So it's like we have to find that balance.
Thank you, Kyle.
Trying to remember the exact question that I'm answering here, but yeah, go ahead.
Can each of you share a moment, personal or professional, when you realized that the way medicine is usually taught or practiced wasn't enough to hold the full reality of care, healing, or human dignity?
I'm not traditionally in the medical field. And hello. I'm not typically in the medical field. I'm in a few others and work as a strategist. However, I have noticed along the way many patterns, and the approach to modern medicine is very different than the approach to healing in the indigenous world. There's a set of values that are driving any system. We have experiences that give us a worldview, that give us, we gain values from that worldview perspective. We value this because of the things we've experienced and the way we see, and then we create priorities around that. From that, we have behavior, and on the other side of that is all the systems that we're talking about. So if we're talking about changing a system, or even just assessing a system, to look back at the values that are supporting that system. Sometimes they're the same as the ones that created it. Sometimes they've evolved over time. Sometimes, especially in the medical world, there are other things that come into play that you have to consider as a physician or as a practitioner anyway. Those types of considerations are not the same in the indigenous world. That it's more of you've got more of a clean territory to work with in terms of the values that are driving it. There are fewer factors impeding on those values, I guess, or challenging those values and priorities. In this, when I see the modern medical world, and then what I've seen and witnessed in traditional indigenous settings, I don't know how to explain it, how much of a different world it is. But there are these values in the indigenous world are based on our understanding and operating from an understanding of our interconnectedness and the profundity of that interconnectedness. they're the web of relationships between humans, between an object or nature or whatever relationship with technology. We have all these relationships. When someone walks in with an illness, that illness, physical illness or whatever manifestation, then that's going to be viewed as most likely a relationship fracture somewhere along the line. Again, relationship is fairly broad in that part of the discussion. And I think there's approaches. We don't look at modern medicine typically as relational. It's more anecdotal, and here's a medicine or a pill. There's a lot of different beliefs even in the idea of healing from something versus curing, being cured of something. A lot of times in the indigenous world, the perspective is more around healing something internally that has just had an outward physical manifestation. Anyway, there's some complex layers there, but one of the things that I've realized is that there's a polarization oftentimes. You do this, you do that, it's this way, that way, wrong, right, and so on. That's not something we experience in the indigenous world very much. Actually, you mentioned up here on the panel before about the third, Parker Palmer and some of that discussion, and there's a discussion around the third way. A lot of the things that we talk about in the indigenous perspective is a third way. I've often joked and said, give me a polarized situation and I'll find a third way. There's another way to come around. We don't make space for that typically in our institutions. And I think that's an important dynamic to bring in, to make space for that third way, for another way of seeing and being. Anyway, I could go on, but I'll leave it at that.
I'm wondering if you could just like build a little bit on what you're saying, because I think it's helpful to take what you said, which is so spot on and so important as we think about our vision of what kind of medical education we want, what kind of healthcare system we want, to think about and amplify like just the starkness of the contrast between what you just described and our current state of healthcare, at least in Western countries. And I think that there's some things from the field of bioethics that bring that home, which is the contrast between a focus in the Western world on individual autonomy and an individual and their rights and how we even think about interacting with the individual, and what you described in terms of this relational approach of the indigenous world and that web of relationship, the interconnectedness of relationships, and what that implies for how we as healthcare providers interact with our patients. What's our relationship to thinking about data collection even? And who's giving consent for that data collection? And is consent just about one moment in time in a very transactional kind of way? Or is it something that's dynamic and has to be ongoing and really a commitment to care when a patient gives us consent to use their data or to provide healthcare? So thinking about that stark contrast between the Western perspective of individual rights, individual autonomy, and the indigenous perspectives of relational accountability, I think is a helpful lens.
And I just wanted to jump on regarding autonomy and consent. So there's an organization called Leapfrog with quality insurance. And if you go on there, all the hospitals are rated, because hospitals, we love a good score. Everybody wants that A, right? Because then it's connected to how much money that the hospital can actually bill for, et cetera, et cetera. One of the most basic things, informed consent. Actually taking the time to explain the procedure in a way that the patient is receptive. Every hospital in the Boston area didn't meet it to its fullest standards. Personal experience, because I'm a Black woman, I'm a researcher, but I'm also operating in a system that wasn't designed for me, nor is benefiting me. So that's a whole other conversation for another time. But surgery, about to go in, they started my pain medication, and then they're like, oh, real quick, we have to do your consent. And I was like, hold up, I'm not like that going right now, but I'm pretty much in altered state. So you need to document and I'm going to check, you need to document in the documentation that you failed to do that because you forgot. And however you need to chart that, do it. So in my chart, the code that was attached to it was non-compliance. Because I'm a researcher, right? So I'm tracking down, I'm gonna get the itemized bill, and I wanna see that, and I had to petition to get it removed. Because that ICD 910 code travels with me, right?
Completely different way of relating to patients, and kind of flip the concept of patient-centeredness on its head, unfortunately.
So my next question is, what is one thing that you've learned about care or healing that you know is real, but the current system struggles to see, measure, or reward?
I'm going to go back to my struggle with mammography and wanting ultrasounds rather than radiation. And no matter who I talked to, no matter what doctor, it was standard of care. You have to have the radiation, and if we see something, then we'll do the ultrasound. And I said, but it's proven that the ultrasound is even better than an X-ray. Why do we have to be exposed to that? I want to resist that. Well, then you won't get the care that you need because this is, and the insurance won't pay for it because this is this proved standard of care. It's solid like a rock, and that's really hard to change. Also regarding statins. So as the years went by, after I stopped cold turkey taking that horrible statin, and after 10 days felt like dancing, well, my cholesterol was always borderline. So just before COVID, the doctor said, you should be on statins. So I said, okay, you find me one statin that has had research done on effects on women. And if you can show me that, I will take it. And so he said, I will ask this specialist at UCLA. So I go back a month later, and I said, so what did the specialist say? He said, tell her to take them. And I said, no.
Kathy or Jared, do you have anything to add to that?
Oh, wait. I've been gifted. Can you all hear me? No. You can hear me now, right? Oh, this is so much better. Okay, cool. One thing is looking for the signals that are not billable, right? So I know that system charting, you have to go in and make sure you go this, and this. But if you're not fully present with your patient, maybe they have said something around, I have this like sense of impending doom, maybe not doom, but I just have this worry, just wasn't going away. Or, yeah, me and my husband, we ended up having an argument, and it's continually, right, for that one time. But if you took the time to actually ask, or maybe we can use AI, right, to figure out, and there's continuity between providers, there might be something going on where they need more food. That food, the nutrition, is actually depletion in a certain nutrient where they're anemic and they could need iron infusion. And so I think those understanding the things that you're not automating, like when you're doing your differential diagnostic process, thinking about that, think about what am I not seeing? What am I not having to document, but what could be happening that is really relevant to this experience right now for this patient?
Yeah, there's a very individualized perspective on healthcare in the West. And in the indigenous world, there is I worked in a trauma space a lot, working with trauma victims and so on. And there, when someone in a tribe has, this varies, not all indigenous are the same, but even Lakota specifically in North America here, there is a perspective that if someone is suffering from some sort of trauma, that is a fracture in the web of the tribe. And it is the responsibility of the entire tribe to be there for the healing of that. And they take that on as a collective notion. It's not just an individual experience. We see that then transferred into Western medicine, where there's also, as a physician, the doctor, you're there to give prescription. You're there to prescribe and diagnose and say, here's the thing. In an indigenous space, there is first of all, the most important thing is presence and being present. know that that's a practice that's carried over into the Western world, but to first be there and to give that patient, if you will, that they're your presence, and to tune in, and then to have a sort of a reciprocal relationship in that, and a understanding that this person is coming also with the knowledge of how to heal their body. And the physician is seen as a facilitator, not just the healer. We even, struggle with that word sometimes as the healer, really being more of a facilitator of healing and activating the healing from the person. It is a very symbiotic kind of relationship as opposed to more of a dictatorial kind of relationship. Just understanding that approach, obviously, knowing that going into any situation, I know that we're kind of starting off in a different way than what I would normally do.
For my next.
Sounds like you're describing the differences between treatment there.
Yes, yeah, and there is a big difference in that, just the perspective on, when we talk about medicine, I think, I wish we could just have like a glossary of things here too, because when I say medicine, I may mean something a little different than the average person or someone else may be talking about medicine. When we talk about healing, it's a similar kind of scenario. Are we healing here? Are we facilitating? I mean, yeah, there's lots of different ways to look at that, but yes, I think that's a good point.
For my next question, I think we can learn a lot from indigenous perspective as well. Like when you mentioned before deep time, can you describe a moment when slowing down, listening longer, resisting a quick solution changed the outcome of care or understanding?
Every time. Again, that's talking about the approach, and I know that when I've had a handful of times of coming into Western care for certain situations that were very acute, and that was an important time to go to that kind of care. Every other time I've gone to a traditional healer. I feel safer in that environment because I know all of the considerations that are there. I know that that person is there fully present with me. I know that they're considering the web of relations in my life, and that I might have this ache or pain or chronic situation because of the fractured relationship in my life. And they're going to account for that rather than just kind of mow over it and say, no, let's give it, here's a pill. It just kind of extrapolates across every different thing that would come up, from social situations to medical situations to education and all the different things. There's a very different approach. We in the Western world are not looking to slow down typically. I feel like somebody asked me last night, like one of my practices, and I was like, slowing down is a practice. I know that I'm a strategist, and I've worked with a lot of astronauts and things that have had a pretty wide career. But in that, there's an astronaut saying, I think that Navy SEALs say the same thing, slow is fast, slow is smooth, smooth is fast. And we don't have time to make a mistake in space. I feel like my elders operate very similarly, and they're very thoughtful about something that's going to happen, or something that they're facilitating or part of. And there's a value on slowing down. There's a value on silence and stillness that we don't value in the Western world. And I feel like we're at a disadvantage in that space. This is somewhat connected, but I think about this all the time because I've been involved with a lot of DEI panels, especially in the space industry and AI and other places like that. And there's this notion that DEI is like some responsibility that we have to include everyone. And I think that's fine, but that's not why I'm there. You know this. I'm looking at this and saying, look, do we think that it is better or that it is more advantageous or less for us to have women involved in the discussion? I hope we don't have to actually answer that. And you go on and on through the BIPOC spectrum and say, like, is it more advantageous to have these people in the room? Of course, it's not just about including them because it's a nice thing to do or because we should feel responsible to do so. We're going to have a better outcome with Indigenous elders in the room, and with Black people in the room, and brown people in the room, and women in the room. So that's been something, as I've worked in the space of women's rights, largely in East Africa for a decade. And that in that space, I found myself constantly coming back and saying, hey, this isn't just about inclusion. I think you've got this wrong. It's not about just a responsibility to include everyone because it's nice. It's more advantageous. I'm a strategist. I want those people in the room because I'm going to get a better outcome. And I think a lot of my work has been around that to sort of help people understand and bridge those worlds that this isn't just about inclusion for inclusion's sake. It's about a better strategy. We're at the stage in humanity. We need some better strategies if we're going to figure out climate change and things like that. And to further that, it's not that we're lacking the answers. Most of the time we're just lacking the will to actually hear it from the people that have those answers.
Did you notice the same thing with like in the clinic about time to slow, like, are you even able to slow it down?
Me personally, or just in the space, so most of my birth doula clients are actually physicians. And so sometimes when they come to me, they're like, do I really need you? And I'm like, you've been growing a baby in an entire organ, yes, you need me. And you need me for your partner also. So slowing down, long, short, without exposing, is that friend of, like, the whole care team, the birthing person, the husband, and myself, we've all been working in medicine. Nobody addressed that coming in. And so when it was time to add medication, Pitocin, to mimic, to speed up labor, because the bed has been occupied for more than 14 hours, and you have to turn it over, and if you don't turn it over, then you're losing money. Slowing down, and she finally said yes to that epidural. When the anesthesiologist came in, they're like, okay, so I'm here. We're like, well, we haven't like decided all the way, but you know what? Come sit down. They're like, what? They're like, no, come sit down. Like, you're not the only one on the floor, right? They're like, no. I'm gonna close the door. Come sit down. So slowing down for everybody, even if it's 5 minutes, can be beneficial. And also my friend who followed, then she put her doctor hat on, and when it was time to actually for a C-section, she was like, hold up. Who? Resident? No. Attending, come on in, and then you can come. And then people were also kind of thrown off because they're like, you can't kick us out. She's like, yes, I can. Like, yes, it's my choice, right? So.
I think you've all mentioned a little bit about relationships. So if healthcare education were designed around relationships rather than outputs, what would feel fundamentally different before we ever change the curriculum?
Should wrap up pretty soon.
Yes.
Yeah, but okay, Mr. Rose here.
Oh, I was just gonna say, in the church in these past few years of Pope Francis and now Pope Leo, there was a huge emphasis on connectedness, of connecting to one another, and that's through communication, and I think therefore storytelling, or in music and art, however we tell stories, that we can connect together as human beings. That has to be the starting place.
Thank you so much. Thank you all for